Good evening, all of you, to the 76th session of the Weekly Huddle. And I'll start with a clinical case today. I'll ask Praneeth for his opinion, and then I will go around the attendees list for their discussion on this topic. So this is a 40-year-old male, and this happened last Saturday. So I'm guessing 4 days back. That day, I actually saw more than 15 of such patients. I'm just putting one of them. And Saturday clinic was unusually busy with patient subset which were similar as compared to what I'm describing. So this is a 40-year-old male. He does not have any comorbidities. He is an IT professional by profession, software engineer who spends most of his time on computer and is currently doing work from home. He got disturbed with the recent news of celebrities succumbing to cardiac arrest, in particular the recent news that came from Bangalore. So he and a lot of his colleagues, they kind of decided to get the so-called routine assessment, because they also thought that if high-profile celebrities can get into cardiac problem, then they should probably also get checked out. There was a sense of apprehension which was quite obvious that I could sense. So he comes from a routine checkup for the similar reason, and also he heard a lot of this online discussion about doctors promoting or endorsing preventive checkups, including few discussions about cardiac CTs. On clinical discussion, he denied any smoking history. He didn't have any relevant family history of early coronary disease or whatnot. His blood pressure at the time of visit was 118/82 and a heart rate of 104. I have this handheld ECG device which I used in my OPD for his heart rate of 104, and that suggested sinus tachycardia. There was no any arrhythmia that I could identify. His physical examination was unremarkable. He brought some of the routine laboratory findings that was done last year as part of his annual checkup, and the blood test that he brought was lipid profile, and I'm putting the numbers in front of you. His total cholesterol was reported to be 182, LDL of 141, HDL of 38, and triglyceride of 122. These numbers are also there on the Huddle WhatsApp group in case if you want to review these numbers. No other labs were done at that time. Now, based on the information that I provided, I calculated his 10-year ASCVD risk score based upon the cohort equation, which was endorsed by the ACC in the last discussion, and that was estimated to be 1.2%. That means his 10-year risk of having any atherosclerotic cardiovascular event is 1.2%, which would classify him as low risk. So here we have a low risk male Indian patient of Indian ethnicity who comes to further risk stratify his chances of having ASCVD event in the future and how we can reduce that risk. So essentially the discussion is how to reduce risk in a person who is already a low risk subset for ASCVD. So the discussion point today is what are the key aspects of history to determine ASCVD risk, taking our patient patterns into account rather than what is described in the Western literature. So what are the historical aspects that you would like to know from this patient other than the one that I have already mentioned? The second question is, what are the first order of investigations for risk assessment, understanding that this patient comes to you without any workup done except the lipid profile which was done a year ago? And how do you define the role of screening ECG, echocardiogram, or treadmill test in this patient subset? We are talking about ASCVD or cardiac arrest or cardiac risk prevention, because remember, a lot of these patients a lot of these subjects, I would say, or general population who have out of hospital cardiac arrest, we don't even know whether they are all coronary event or whether there is something else going on. And is doing CT coronary angiogram the way forward for everyone? And the reason why I put up this case is because recently there had been some discussion, and in fact, I wouldn't say recently, every single time when a high profile out of hospital cardiac arrest happens, then somewhere or the other, this whole discussion of screening CT coronary angiogram is touted by a few people. if not many. So is doing CT coronary angiogram the way forward for everyone, particularly this low risk subset that we're talking about? So Praneeth, how would you take this case? And I do say that he is low risk to begin with, and we are trying to reduce risk of an already low risk patient subset. So 4 questions for you, and if you need any information, please ask me, I'll provide it. Praneeth, on to you.
Yeah, good evening, everyone. I'm sure, just like you, almost every cardiologist practicing has encountered this situation in the last week or so. And similarly, even I have encountered the discussion, I think, is relevant today. So this patient, as you already mentioned, Anoop, I believe the most important thing is history. You already mentioned a few things. I would approach this patient as whether the patient has a risk of having ASCVD. Then I look at the symptoms and then support it with labs. This patient does not seem to be having any relevant history. The traditional risk factors of hypertension, diabetes, dyslipidemia, smoking, and a family history of any sudden cardiac death, these are some things which I would like to look into it. I believe these are not there in this patient. In the lipid profile that you mentioned, LDL seems to be slightly high, somewhere around 140. If you look at the traditional targets for prevention, then that LDL should be less, but I could see only one risk factor for him. There are no other risk factors. Symptoms are also not there. Clinical examination is unremarkable. So, and as per the ACC risk calculator or risk estimator as well, he falls into low risk. And all this apprehension is probably because of the event which is changing the behavior, as you said. So firstly, I would try to reassure him and tell him that about the low risk, and repeat because they are these tests are somewhere done about a year back. I would repeat him, start with an ECG, echo, and lipid profile, HbA1c, look at his diabetes, and moving forward, I would get a CT coronary calcium scoring for him, understanding that the probability of he having calcium score is low. Also trying to highlight him that zero calcium scoring doesn't mean that it is zero atherosclerosis. But if he has any calcium scoring at 40 years of age, I do not expect any calcium. But if he has calcium, then that also indicates that he has high risk of having atherosclerosis, and I would be tempted to advise him to take statins for prevention of ASCVD. So I would start with ECG, echo, coronary calcium scoring, HbA1c, and lipid profile in this patient. Reassure him, follow with these investigations.
Few questions I'm going to ask you. So while these are standard of care, whether they are supposed to be standard of care. So let me ask you a question. So screening HbA1c in a patient who never got screened for diabetes makes sense. Lipid profile maybe makes sense. He already has one, which is not terrible. What are you looking for in ECG and echocardiogram? Is it justifiable?
To look for any patterns of LVH or any patterns of pointers of any arrhythmogenicity in the form of any Brugada pattern, any ARVD which can be subtle, or any long QTs which can be there. So these are something which I'm trying to look into because these can be the manifestations of sudden cardiac death. So the reason for looking at ECG is to look at these markers in addition to any other subtle markers. But these are the three important things which I would look into, and any other things. And in echo, overall LV function and any valve abnormalities, because patients can again be asymptomatic or the symptoms are masked. So I want to be definitely sure that his cardiac function, or he has a structurally normal heart to begin with. So whether this can be justified, I believe yes, they can be justified as an evaluation, particularly when I'm trying to reassure him that there is nothing wrong with you. Having an objective evidence to will help me reassure him better.
And how about calcium scoring? Again, we are trying to figure out, should calcium scoring be a part of all the risk assessment tool?
With the data on calcium scoring predicting future ASCVD events, so that is where I'm advising CT coronary calcium scoring, because it has been having a positive correlation in predicting the future events in the 10 years, so to speak. But whether that is relevant or we should make it mandatory, I'm not completely sure, but because it is easily available, it does not take much of the time, no specific preparations, CT scans are reasonably available everywhere. I think that is reasonable alternative. So I would say yes.
And how about CT coronary angiogram as a screening tool?
So coronary angiogram, the challenges are the what you call giving the contrast to the patient, which requires its preparation of looking at the renal function test, then making sure that the heart rates are well controlled. Then there should be technicians available and interpretation. These are some things which I believe challenging, and equally the CT scan machine should be equipped and gated to acquire the images. So I believe getting these things as a routine will be a bit difficult, particularly in those odd hours when we want to evaluate in the middle of the night chest pains, where we can get the investigation, but there is nobody to interpret as well. So in that regard, I am not in favor of CT angiogram, but I am favor in doing calcium score.
Okay, Praneeth, I'll continue my discussion with rest of the attendees here. May I invite Dr. Vijay? Vijay sir, I'm sure these kind of cases, they come to you, and other than commenting on the clinical case that I'm discussing, my particular question to you is, and I'm going to ask this to everyone, whosoever is sharing their thoughts here. When we say low risk, we are talking about low risk means less than 1% annual risk of cardiac events. But my question is, a general population, a healthy 40-year-old, why should he settle with less than 1%? He wants 0%. He wants that his 10-year risk of ASCVD should be 0%. Can we as a cardiologist do something extra to put a low-risk patient in low-risk subject into even more low-risk subject? How can we do that? Because even if we say that, let's say your 10-year event rate is 2%, let's say, which would still qualify you as a low risk, a 40-year-old, all the 40-year-old individuals in India, 2% of them will have a cardiac event over next 10 years, and that would be a lot of people. And if some of them are celebrities, then they make a huge noise. And that has got downstream repercussions on how community looks at cardiovascular prevention. So, Dr. Vijay, how would you handle this particular patient who comes to you? And do you have a suggestion for the question that I'm trying to ask, or am I being too strict about what I'm trying to get? Dr. Vijay.
Good evening, Dr. Anoop. My point was here, this 40-year-old gentleman is a software engineer. So his lifestyle is almost a sedentary lifestyle with no physical activity. That is one of the risk factors for him. His lipid parameters are almost not very abnormal. The first and foremost thing is we should remember is he's a South Asian, he's an Indian, which is a high risk race for this thing. And based on this ASCVD score, which is around 1.25, which comes under low risk, but there are certain risk enhancers which put them still more at risk. And ASCVD risk, there are a lot of risk source, and ASCVD risk source, I think it is not applicable to Indian scenario. There are British, Europe also, there are different risk model scores. In this patient, I would like to be regarding calcium score. The calcium score is 0. The risk of having events in the next decade is almost negligible. So I strongly recommend CSC, but not coronary angiogram, because it is expensive. It is a contrast induced, some nephropathy, all those things. And in a country like India, where 1.3 billion people are there, the advising a CT coronary angio for all patients who are having 40 years, I think it doesn't seem good and right also. So my point was to assess the basic investigations like ECG and echo, treadmill, lipid profile, all those things, and advising. And we should assess the patients. And most of the patients, they think that they are dying because of CAD only. But I feel we should assess the masked diseases like long QT, as pointed out by Dr. Praneeth, long QT interval syndromes, Brugada syndromes, and ARVD and HOCM, MVP with arithros. We should all those things. That is my view. Thank you.
Sir, a few questions before you mute yourself. So in this particular patient, you made it very clear, you will order a calcium score on this patient?
Yes, definitely.
How about HSCRP?
Yes, HCRP. Yes, HCRP more than 2 also is one of the risk enhancer. I will definitely order.
So in this patient, you will order both of them?
Yes.
How about TMT?
TMT, yes, because his LDL is around 141. There is slightly above normal. I would advise in scenario.
Okay, sir, because you have been practicing here for quite some time, this is one question I'm going to ask you, because I don't have an answer for it, and science as a general do not have an answer for it. Would you be checking his vitamin levels? Do you think that has got some propensity towards future event like homocysteine or B12 or that kind of stuff?
Homocysteine, there is a lot of enthusiasm in 2000 and 2001. There is people are all young patients. They are screened for homocysteine. The homocysteine is the more than 15. They used to start folic acid, all those things. But the thing is, homocysteine is now a forgotten risk factors, and it is, in fact, it is removed as a coronary risk factor. I don't screen.
Perfect. Thank you, Dr. Vijay. We will get back to you with more questions. And if you have anything to add in between, you can please raise your hand. Thank you.
Thank you.
Dr. Shankar, if I could get your thoughts on this particular case. And my question is again, same thing that I'm going to ask everybody. Let's take example of what happened in Bangalore. A film actor, he gets a sudden cardiac arrest at the age of 45. While we don't know the cause, in most likely scenario, I would guess it was a coronary event. I hope that more details come out, then we will know exactly what happened. So this is the guy who could have been the same patient a year ago with a similar kind of scenario that I'm presenting this 40-year-old. And if we say 2%, that means thousands and thousands of young individuals in their 40s, they will have an acute MI, even when we would label them as low risk by the current standards, just by the sheer volume of people that we have. So my question again comes to the same thing, that why do we settle at 2%? Why not 0? How can we reach 0? Do we have a way to figure out any CT coronary angiogram that way? So Dr. Shankar, how would you take this patient if he comes to you? And if you have anything to add to the question that I'm trying to ask.
Good evening to all. At the outset, I thank Dr. Agrawal and Palamuri. Happy Diwali, Festival of Lamps, Festival of Lights. This is because recently we lost celebrities with cardiac arrest. So Puneet Rajkumar, Siddharth Shukla, Saurav Ganguly, young budding physicians, cardiologists in Metropolis, they are suffering or dying also for coronary heart disease. So everybody is panicky about it. Earlier also we discussed regarding the thanatophobia. So most of the people have gone into that thanatophobic atmosphere, having seen physically fit people dying all of a sudden in the gym or so having discussed by Dr. Praneeth and Dr. Vijay Kumar, I want to add in this individual, especially I look for lipid abnormalities like lipoprotein small a, if it is more than 20, and it is a risk one. More than 20 to 49, it is a moderate risk, and more than 50, it is a high risk individual. ApoB also I asked for ApoB, where if it is more than 130, it comes under high risk group. HSCRP, if it is more than 2 milligrams per liter, then it is also a risk factor. And ankle brachial index, if it is less than 0.9, these are all indicative of a high risk individual with ASCVD. And homocysteine is, and chronic kidney disease also one has to look for. Urine albumin creatinine ratio, blood urea nitrogen, and serum creatinine also should be looked for, because one of the risk factors for the ASCVD. Having known about the major risk factors of this thing, risk enhancing factors, then we know that South Asian ethnicity also we have elicited, and whether the patient is having any components of a metabolic syndrome also should be, but here the patient is not having metabolic syndrome components, except I don't know the weight or the BMI of this patient, whether it comes under overweight or obesity. Then we should look for psychosocial factors. We just now alluded to broken heart syndrome. Though it is rare in this age group, but the most commonly seen in the postmenopausal woman, that Takotsubo or stress cardiomyopathy. And I want to highlight one point here, the COVID illness. This pandemic, COVID pandemic era, we should elicit any history of COVID illness, because COVID illness patient may present with myocarditis, sometimes with acute coronary syndrome. Both mimic each other. So we have to elicit COVID illness. Even though the patient has not suffered from COVID illness, the subclinical or subacute myocarditis or subacute coronary events may occur. But one has to keep in mind that this COVID illness, COVID-19 illness, it is we should elicit and we should keep in mind. I don't know whether it is relevant or not. We should elicit the history of Kawasaki in childhood. Kawasaki disease is the multi-system inflammatory syndrome. So below 5 years of age, if he suffers, this will progress to the adult age and may land up with acute coronary syndrome. In women, suppose if the patient happens to be the lady, then we have to elicit the history of oral contraceptive pills, any premature menopause, any past history of eclampsia or preeclampsia. These two things should be elicited in case of ladies. And illicit drug usage, this is quite common in even in the metropolis. especially even in Hyderabad. So illicit drugs like cocaine is notorious for ACS. And the second is marijuana, that is smoking ganja, consuming cannabis alkaloids. One has to elicit this history of illicit drugs. And one more thing is inflammatory diseases also we have to elicit, like rheumatoid arthritis, SLE, systemic sclerosis, HIV, especially HIV. We have to elicit the history of HIV, whether it is positive or negative, because HIV, even the drugs, protease inhibitors also, they are prone for lipid abnormalities in the ACS. So psoriasis also is a skin disease. This is also quite associated with coronary artery disease. So inflammatory diseases, these Kawasaki and COVID illness, these are all supposed to be elicited in the history because they are all forerunners of this acute coronary syndrome.
Shankar sir, you brought up a lot of discussion points. I think many of these, I must admit that as cardiologists, we really don't delve that much into. One thing that did catch my attention is Kawasaki disease. So most of the patients that we would see in their adulthood, if Kawasaki is causing vascular disease, that is most of the time a burnt out disease. So I'm guessing that in the physical examination, if we find any absent pulse or difference in blood pressure or whatnot, then it will trigger our thought process. But other than that, how do we elicit childhood history of Kawasaki? Do you have tips to ask, like these are the key questions to be asked for history of Kawasaki?
Only multi-system involvement, and previous reports are there, because even the COVID illness also in the present pandemic era, if it affects the children, they will have Kawasaki-like symptoms only, the multi-system inflammatory syndrome, where the patient will have, apart from myalgias and the arthralgias, the rash will be there. So multi-system involvement will be there. Other than that, I don't know, but because third wave involves the children, everybody is suspecting and expecting. That's why I've gone through what will be the presentation in the children. So it is a Kawasaki-like presentation in children during COVID pandemic era. Same patient, the patient had Kawasaki in his childhood. If it progresses to coronary heart disease, in the coronary angiogram, we'll see a coronary vasculitis and aneurysmal malformations will be seen. I don't know whether it is observed by the cardiologists. This is in the literature, it is there. Kawasaki is also one is a forerunner of coronary heart disease.
Sir, we do see a lot of Kawasaki's, and I wouldn't say many, but we do see quite a few every year. And most of the diseases that we see are burned out disease, and we are not able to trace when the patient had an active illness, because most of the time the illness is not that severe and it misses people's attention. And they are mostly treated like any other regular fever-like illness or a febrile illness where they take some medications. Typically, they are poorly evaluated and poorly treated. And many of the times, by the time they come to us with coronary aneurysms or thrombotic diseases, it's a burned out disease. So for us, it's just like any other obstructive coronary illness, which is treated mechanically rather than with anti-inflammatory. Many of the times, the inflammatory markers are also negative. Having said that, I do acknowledge that when we are screening young individuals, particularly females, we should put our thought into inflammatory illnesses, and that should put us an impetus to check for their pulses, peripheral pulses at least, check blood pressure on two sides, and make sure that we are not missing something as important as vascular disease. What you mentioned about the woman's health is also equally important. For young women, we typically tend to be a little bit more discounting of their symptoms and whatnot, but eliciting their old symptoms, particularly their pregnancy history, and the fact that they are more prone to inflammatory illnesses, I think that these are things worth looking into in primary prevention. And again, I'm trying to make sure how we can reduce that 2% to less than to 0% or less than whatever it is, so that we don't get to see this. Anybody else has got any thoughts about this, so that I don't have to pick up individual names? Anybody who wants to add their thoughts? Santosh, you shared some document with me the other day. Can you elaborate what was that document about? Something related to CT angiogram. Can you just tell all of us what was that document about?
Sir, this is because recently Siddharth Shukla, who died because of cardiac arrest. After that, Mr. Iqbal Singh, Commissioner of Municipal Corporation Greater Mumbai, he, along with one of the NGO, they wanted to screen all of the employees of MCGM, including whoever is working under MCGM. All these major hospitals of Mumbai comes under MCGM. So they want to investigate them for this underlying heart disease. That included mandatory coronary angiogram as well as a lipid profile. That circular was about the same, sir, what I shared. So even I don't know how, whether now it's implemented or, but circular is being sent to all the heads of the department and all the hospitals to mandatory screening of coronary angiogram to look for underlying coronary artery disease. This was in September 2021, sir.
And you don't know if that has been implemented yet?
Yeah, I tried to contact, but I couldn't reach out today, sir. So meanwhile, I lost this thing.
So the question that comes is, and this is again open for all the attendees today, let us say even if we do screening CT angiography to all low-risk individual, is that a tool that we can use to reduce the 10-year event rate from 2% to 0.5% or 0%? Does a normal CT coronary angiogram plus a normal lipid profile, does it guarantee that young individuals are not going to die while exercising or working out at their gym? Because if the two tests can pretty much assure that they are not going to die, then I will advocate that maybe it is worth doing these two tests. If that reduces the risk from 2% to 0%, then why not? Let everybody get this test done. But I'm not quite sure if it actually reduces the risk or not. I'm inviting anybody's suggestion about, do you think that we should be routinely doing these tests? Does it add value? Forget about the logistics of it. Praneeth mentioned about the availability, the cost, the contrast, the radiation, the reader may not be available at night, and so on and so forth. I'm telling you that, let's see, there is a hypothetical scenario where you have all of them available 24/7 and CT angio costs nothing. Even then, do you think, or is there anybody who can share their thought about doing CT angiogram? Will that reduce the risk further than what we can otherwise ascertain by tools that has already been discussed, which is lipid profile, calcium score, screening ECG, echocardiogram, and what Shankar sir said about lipoprotein A or ApoB or all those kind of things. Is there anybody in the audience who would believe that these tests would add value? Even if we say cost is not an issue, availability is not an issue. I typically ask Somaraju sir towards the very end for his thought process, but maybe this time I'll take an exception and I'll ask Somaraju sir early on about what his thought process on this topic is.
You mean in Bombay example?
Sir?
Yeah, it's absolute nonsense what they're trying to do. And when medicine is left to politicians, that's what will happen.
Okay. Sir, but the problem here is, and I'm playing devil's advocate here, the problem here is, while we say CT angiogram is nonsense, we are still not happy with 2% risk over 10 years. I am a healthy 40-year-old individual. I don't want to have 2% event rate over next 10 years. How can I reduce that?
Yeah, I'll add something more about this particular patient, but at this time, I would say more than CT angiogram, more than anything else you do, and measurement of his blood pressure, his weight, and his BMI, and his physical activity, exercise, the food he eats. Food is medicine. So-called causes of causes. His lifestyle, where if he is not smoking, is he a passive smoker? Whether his workplace or friends smoke, and then is he on shift duties? All these things matter. All these things are going to decide what he'll have in future, and not. And we see not only CT angiogram, we know of patients where an angiogram is normal, but the patient drops dead within a week. And this story is everybody's knowledge. And those lifestyle factors do matter. They have to be taken care of. That's what I want to say.
And Samaraju sir, one more question. And before you answer this question, I will remind you and everybody that all the huddle sessions are recorded. So whatever you say will be in the public domain. Samaraju sir.
I don't mind saying that again.
Okay. Sir, no, because I'm going to ask you a very particular question. Sir, in your opinion, and I'm sure that none of us know the details of what happens with these celebrities' deaths or celebrities getting heart attacks and whatnot. But in your opinion, high profile individuals, young individuals who would otherwise be classified as low risk, take Mr. Saurav Ganguly, for example, or Siddharth Shukla, for example, or recently Mr. Rajkumar, for example, and there are many more. And then there are few politicians who are not necessarily in their low risk; they're in their 50s and 60s, but they are also getting cardiac arrest. In your opinion, and I understand that just like me, you also don't know the details of these individuals' lives, and we would never know that. But in your opinion, these individuals getting into problem, is it just a random event that would happen with any one of us? Or you think there could be a systematic problem with celebrity deaths or with celebrities getting into cardiac problem? What is your opinion, sir?
Well, number one, I would say, without going into individual this one, and exercise and physical activity are important, but that's in moderation. Strenuous exertion, endurance exercise is a risk factor for sudden death, even in otherwise normal persons. And having said that, many of you already enumerated the chance of sudden death, including hypertrophic cardiomyopathy, Brugada syndrome, prolonged QT, and underlying structural heart disease, coronary anomalies, whatnot. I will not go into this except telling you, when you talk about, say, cinema field, cinema actors, they are under great stress themselves. The stress is, in one movie, they have to be looking overweight, another movie, they have to look very lean, and in between, they have to eat and do everything to make it happen within a short period. We know of many examples. There is a rapid gain of weight and rapid loss of weight is a significant issue that many of you are already aware. And secondly, the type of food they eat to try to lose weight, to gain weight is anybody's guess. Considering all this, cinema actors, particularly because there's a recent example, and also strenuous exertion to try to maintain themselves, etc., in the itself as a risk factor. And so don't take it for granted. The person whom we are talking about in Bangalore, and he may be in perfect health, but his lifestyle of the type of activity, the type of food they have to eat, gain weight, lose weight, etc., that endurance exercise, too much of strenuous exercise itself is a high risk factor.
So, sir, if we identify these kind of individuals who have these risk factors, like what you mentioned, or they are in high risk profession, if you say that movie actors or sportsmen or those they,
No, particularly not
sir, you got muted by mistake.
sportsmen sudden death, but particularly cinema actors
Particularly cinema actors. So,
and heroes, particularly.
so
And
if
they are under, I won't mention names, but they
Yeah.
are under high risk.
So, sir, if we consider them as high risk, is there a different set of screening protocols that they should undergo than a routine individual like the one that I gave example of a 40-year-old IT professional?
Yeah, when they have to be advised about these issues and risks of this lifestyle, and then these have to be kept in mind by physicians or cardiologists who look after them and tell them the risks involved. And moderate exercise is useful, but strenuous exertion and over endurance exercise is a risk factor.
Thank you so much, sir. I will continue my discussion and I will invite anyone who has any thoughts to share about this particular topic. And while you gather, I will start asking individual opinion. Shankar, sir, you have something to add?
The normal coronaries in the patient has got ACS or sudden death is quite known because that topic itself is a MINOCA, that is myocardial infarction in normal coronaries. In that, the stress cardiomyopathy will come. And sir has told, Dr. Somraj sir has very much alluded to that strenuous exercise, because this is a main culprit for the IOT, this coronary artery dissection. This is or plaque rupture. So, because recently there are many video, it has been viral. The heavy weight lifters suddenly they collapsed. So just like it is almost a commotio cardis. So strenuous exercise or myocardial injury will occur, or else the coronary artery dissection will occur and the patient will die. So this is quite commonly seen in the postpartum period, this coronary dissection. Probably experiential, like you people know better than me regarding the coronary dissection during the postpartum period and strenuous exercise. And the third one is the thrombophilia, the factor Leiden or protein C deficiency or protein S. These individuals suddenly they may get coronary clots and they may have sudden cardiac death or ACS, acute coronary syndrome. And one more thing, this is very peculiar to me, that is a paradoxical embolism. In the presence of a patent foramen ovale, the paradoxically the emboli enter into the coronary vasculature and give rise to this obstructive coronary syndrome. So this paradoxical embolism, the experience like Dr. Somrazu sir better enlightens me regarding this paradoxical embolism, thrombophilia, and MINOCA and coronary dissection. And lastly, to reduce this risk in this patient, even though it is a low risk 1.2% ASCVD over a 10-year period, I better start, even though he is 40 years old, he is actively, he can be given low dose, low intensity statin, either 10 milligrams of atorvastatin or rosuvastatin 5 milligrams I start in this case, because LDL cholesterol is also elevated more than 141 here, and HDL-C also, the lipid abnormality is there in this case. So I start him on atorvastatin or the rosuvastatin. Thank you.
Sir, you mentioned about thrombophilia.
Yeah.
And again, the question keeps coming out the same thing. When we start looking at the various causes of why young people would have problem or they would have a sudden death, there are innumerable causes, and thrombophilia is one of the important ones that you mentioned. The question again comes back to the same thing. When a young 40-year-old person hits your OPD, what all are the things that we should screen them for? So if, let us say, thrombophilia is a cause, yes, we know it is a cause. Should we advocate people that, should we advocate ourselves to say that we should routinely be screening these subset of normal population for thrombophilia or for PFO or for all this? Because unless we start looking at these things, we won't be able to reduce the risk down. So other than saying that, okay, you have got a 1.5% risk and that will remain, we are not going to do anything about it. Do you see any way out? Like how can we reduce the risk other than just enumerating the causes? Shankar sir, do you find any value?
Okay, sir. We have to investigate, sir, because in the subset of subset of patients only we investigate like this, because the patient gives history of DVT or a past history of any pulmonary embolism. So that will lead us to investigate for these thrombophilic factors.
Right.
So I have mentioned because to complete the discussion, because these are all things to be kept in our mind before we say why he died suddenly, though he is physically fit and no comorbidities.
Right, exactly, and that is where I think the problem comes. That while we know that these are the possibilities, many of the times the very first presentation these guys are going to give it to us will be a cardiac arrest, and that will not give us time to evaluate. So even in this subset of population who do have an event, other than just finding the cause of it, I don't know what can we do preemptively to reduce those risks. What you mentioned is very pertinent, that if patient lead us somewhere, if their history leads us somewhere, like DVT or whatnot, or psoriasis, if the history leads us somewhere, then it makes sense for us to evaluate. But a routine Joe who comes to our OPD, who do not have any leading history, how do we evaluate for those? Is it justified to screen for all of these? And the answer that I'm getting from you and most of us is probably no. Praneeth shared two things in the chat box, and I'm going to put both of it for the discussion. And if anybody wants to take up either one of them. One is he mentioned Western Denmark Heart Registry, and I have to look into it, Praneeth, because what you are mentioning is very scary. Western Denmark Heart Registry, more than 25,000 cohort with a 0 calcium score, 1 in 7 have obstructive CAD. That is scary. That means 13-14% of normal population who have a 0 calcium score have obstructive coronary artery disease. I want to say I don't believe this data. This is too scary for me to believe, because what we do know is that yes, sir.
Anoop,
Yes,
I have
sir.
to add here while you comment on this study or whatever it is.
Yes, sir.
CT calcium score has enormous limitations. It depends upon the age of the person and duration of atherosclerosis. Young person with atherosclerosis may have 0 calcium score, but may still have significant, say, vascular disease or atherosclerosis. So it depends upon whom you are testing. And calcium score again doesn't mean obstructive disease. In a young person with a lesser score, it doesn't rule out significant atherosclerosis. That's extremely important to keep in mind, and this study should not completely ignore it.
Right, sir. I think what you started with, I'll complete the discussion. We did have a discussion on calcium score before. For everybody listening, I'll just add on to it. So limitations of calcium score, two common things that is there with us. As Somaraju sir said, if you do a calcium score in a 30-year-old individual, if the calcium score comes 0, you still have not excluded non-calcified soft coronary plaques, that you have not excluded. And by that time, by age 30, you don't expect the plaques to be more than, let's say, 10% burden or 20% burden. You don't expect it to be more than that. But remember, calcium score is not going to pick it up. If you order a calcium score in a 60, 70-year-old individual, even low-risk individuals at the age of 60 and 70 may have a little bit of calcium in their coronaries. Their calcium score may come around 50 or 100, which, truly speaking, I don't know how to interpret. And I don't know if there is any data that tells us how to interpret. So a lot of the time, calcium scoring is for those intermediate patients where you don't know which subset in the risk that they fall into. Do they fall into low, intermediate, or high risk? A person who is already determined to be low risk, a negative calcium score is not adding any more value. A person at the age of 60, 65, just by the sheer age of it, they do have risk of atherosclerotic heart disease. For them, having a calcium score of 50 or 100 is not adding any more value than what you already have. So it is very pertinent that we order the scoring in the correct population and we interpret it in the correct way. So that kind of...
I'll just add one thing. I'm sorry for
yes, sir.
intervening in between. It has to be combined with the rest of the clinical information. Symptomatic versus symptomatic, or evidence of ischemia versus no ischemia, etc. Calcium score in isolation is absolutely useless.
Right. I think that is also a point that is worth mentioning. The second thing that Praneeth brought up is, and Praneeth, by the way, this Western Denmark Heart Registry, if you could just share the link of this study on the WhatsApp group so that we can look into that. The second question that you put up, and if anybody knows how to answer this question, please come forward. How should we screen someone who wants to do high intensity workout? So let's say a person comes and he says that in fact, I had a patient like this just last week. This person is a trainer in one of the societies, in one of the government societies, like a firefighter society or something. And he came with a letter that it specifically asked a cardiologist to clear him to participate in high intensity training, where he will be training the upcoming firefighters. And I had to clear him. So anybody can share their insights about how we should screen people who want to do high intensity now, since we have established that high intensity workout is a risk factor for cardiac event. I wouldn't say coronary event, but a cardiac event. Is there a particular way we should be screening other than regular ECG, echo, and maybe a calcium score, maybe lipid profile or whatnot? Anything else that we can do specifically? And I don't know. I don't have an idea how you do it. What I do, Praneeth, is when they do want to participate in high intensity workout, I put them on a maximal tolerated treadmill. That's what I tell them to do. That go on a maximally tolerated treadmill where we get a periodic ECGs on that. We don't wait for 80-85% target heart rate. We just tell them that you exercise till you get tired, and we see if there is any rhythm disturbance or any ST changes. I don't have any data to support what I'm doing, but to my limited knowledge, that is what I'm doing when I have to screen for these patients. But again, I don't know. Is CT angiogram an answer to these patients plus an echocardiogram? I don't know. If anybody has got any thoughts, they please feel free to share their thoughts about it.
Dr. Anoop?
Yes, sir.
While you may screen, when very high intensity exercise in isolation is a risk factor that has to be explained to them. If they still want to do it, let them do it.
Right. I think that point needs to be mentioned very clearly, that high intensity exercise may precipitate a cardiac event, and high intensity exercise by itself could be a risk factor for future events. So something which is normal now may not be normal in the future as well. I don't know how much of systematic data is there on this. But definitely there is enough of observation between the doctors and also the data set, which suggests that high intensity exercise is associated with cardiac events. I also believe a lot of it is non-coronary events like HCM and arrhythmic events, but I wish there was a systematic data on this. And if anybody can find any...
Anoop, I can refer you to one of the, at least some data made available on several years ago. One of the issues of progress in cardiovascular disease, dedicated the whole volume on exercise. And in that, there's one chapter is high intensity exercise that can be used.
So you said progress in cardiology, right?
Cardiovascular disease, PCVD.
Progress in cardiovascular diseases, exercise, right?
Yeah.
I'll look into it, sir, and if I find the link, I'll share it with the attendees here so that we can refer it for our future discussions. Anybody is doing carotid intimal media thickness or peripheral vascular duplex exam as a risk stratification tool? Anybody is doing this in their practice? Has any ideas to share? CIMT has recently been dropped from ACC as well as ESC guidelines as an effective screening tool. But I remember 10 years back, a lot of us, we used to do CIMT. And same thing as a peripheral vascular Doppler exam, not the ABI. ABI is a standard risk tool, but peripheral Doppler. And the idea of doing peripheral Doppler is that ABIs, screening ABIs in an otherwise low risk subset is a very low yield test, because in far majority, ABIs will come normal unless the peripheral vascular disease is very severe. So the whole idea is that you do arterial duplex to identify even those small plaques in the femoral or iliac or SFAs, which would be an indirect way of telling that there may be coronary lesions as well. So I have not incorporated that in my practice. I'm curious to know if anybody in the attendees are doing it as a part of screening tool. Okay, so it doesn't look like that. That is also something which comes very, very frequently. Shankar sir, you mentioned about lipoprotein A and ApoB. Is it something that you are routinely ordering in your patient subset, and how do you order it? Because I believe the standard lipid profile does not include ApoB and lipoprotein A. Do you give some certain instruction? Are there certain labs which do it?
No. In certain high-risk individuals where there is a family history or premature cardiovascular disease in the family, I specifically mention these things to be there in the report. But nowadays, even in the ThyroCare or SRL, I don't want to mention the names of the labs, but everybody is giving extra reports, but we don't have treatment for them. Actually, in the lipoprotein A, if it is there, elevated, we don't have medication which are affordable. The PCSK9 inhibitors or inclisiran. We don't have bempedoic acid. We don't have those molecules with us. But at least we know the risk factor in these individuals.
Yes, so
and
certainly.
This regarding this the carotid intima media thickness, regularly we used to order to document evidence of ASCVD. Suppose if it is only increased CIMT, then we say that it moderate this. And even myself, I underwent this carotid ADM media thickness, and accidentally I was found to have a non-stenotic carotid plaque. It is a high risk, so I am on high intensity statins also.
Sir, that is very relevant. Actually, there was this whole thought about CIMT 4 millimeters, 7 millimeters, and whatnot, and there was a lot of this tracking whether CIMT could be a risk assessment tool. As I said, that it has been recently dropped for the reasons that it is not discriminatory more than what the conventional tools are, which are your HSCRP and your calcium scoring and whatnot. So while it was dropped, I believe you got it at the time when CIMT was one of at the forefront of risk assessment tool. And I believe at that time, a lot of people were doing it both for clinical as well as commercial reasons. And a lot of patients at that time got a CIMT done, just like in early 2000s when hospitals got their EBCT machines installed, every person was getting calcium score at that time. So those are some of the risk parameters. I don't know still what to do with that 40-year-old person who came to me. He, by the way, the questions that were asked, he is sedentary in his lifestyle. His BMI is about 24. He is not obese. He does not have shift work, but he is not moving that much in his life. So a lot of the discussion at that time went towards lifestyle. I did not order any special tests on him other than routine blood tests. I did order ECG and echo, although I don't know how much of that yield is there. I understand the rationale of screening for arrhythmia and for HOCM, but I still don't know how much of the yield that it comes through. I didn't order calcium score. I didn't order HSCRP. It does seem like ordering HSCRP may be a relevant thing at this time. CT angiogram, I have no idea. I'm still kind of debating about it because there is a lot of discussion on the social media. And there are patients who are demanding, like what Santosh was saying, that there is a community which is actually endorsing to get CT angiogram of all of their employees. So a lot of this discussion, if we haven't discussed yet, this will be a part of our discussion if we are practicing cardiology or preventive cardiology medicine in our life. And we better be prepared at least with some of those answers that patients are going to ask us. With that, I would ask Praneeth to give his closing comments unless somebody has got any thoughts to share. Dr. Shankar, you have anything to add?
Only one thing I add to the august audience, insightful thought. When the patient comes with a syncopal attack during stress or during vigorous exercise or chest pressure, so that may be the clue to an anomalous origin of the coronary artery. Anatomically, this lesion occurs most often when the left anterior descending artery or the left main arises from the right coronary cusp and traverses between the aorta and the pulmonary trunks. This slit-like orifice that results from the angulation at the vessel origin is thought to cause ischemia when the aorta or pulmonary arteries enlarge during vigorous exercise. During vigorous exercise, these aorta and the pulmonary arteries, they enlarge, and that will cause the angulation of this anomalous artery and brings about a slit-like orifice and causes ischemia. So the tension is placed on the coronary artery. So whenever a patient gives history of syncopal attack during vigorous exercise, one has to think of this anomalous origin of the coronary artery. This is an insightful thought I've got when I was going through literature.
Can I?
Thank you, Shankar, sir. Yes, Dr. Gopikrishna, please go ahead.
Can I add one thing, Dr. Anoop?
Sir, please go ahead.
Now,
Please go
the
ahead.
interdepartmental evaluation or interdepartmental discussion or referral, I found some surprising things actually. Sir, what Shankar sir said, like a syncope patients, I'm frequently getting these patients with a syncope. First, most of the patients, they go to the neurologist only. So, I have seen some of the patients when they are getting recurrent syncopes, and after evaluating, which is nothing is found. But within few days or few months, they are coming like with a history of same syncopal attack or loss of consciousness without chest pain also. After admitting and evaluating, they are found to be like LMCA lesions. What sir said is like a anomalous coronary artery is a one thing, but the same thing, LMCA diseases, they present like a syncope only, especially in the diabetes without pain, other things. So most of the time I am seeing in my observation that LMCs we are frequently missing. And the thing like a syncope is the one thing I think which need to be give more attention in evaluating cardiac arrest. Most of the time this goes to the neurologist and they do EEG and MGs and they say it's normal, nothing is there. And most of these patients who are having the tendency for future sudden cardiac death, I think we are missing with by not getting these type of patients to the cardiac OPDs. So we need to educate our fellow colleagues also regarding these things in preventing the sudden cardiac deaths. I request uh, the persons like the doctor like you or Somraj sir or somebody else to give the valuable opinions regarding this point.
Dr. Gopakrishna, I think what you bring is absolutely pertinent. And syncope is a cardiac evaluation, and it is very unfortunate that many of the times it turns out to be a neurology evaluation. I remember during my training, one of my cardiology attending used to say that if a patient has got syncope, then the last department that you ask for a consultation is neurology. You ask every other department, including you as a cardiologist, and the last person to ask for is neurology, not the first person. While syncope it does seem to be a CNS event, most of the time the trigger is not CNS, trigger is somewhere else, and cardiologists need to be at the forefront of it. And ischemic lesions like left main is certainly one of the differential diagnoses. There is no doubts about it. Again, I'm circling back to the discussion. We are discussing about patients who do not have any symptoms, who are completely fine, who come to you saying, I'm absolutely okay. And they become our main challenge. Symptom evaluation, we can discuss about how to evaluate, what to evaluate. But here you have patients who are asymptomatic, who feel absolutely fine, who do not fit into any traditional risks that you put them on. And they still have a risk score of 2% over 10 years. And they would be like, why should I have 2% risk over 10 years? I'm doing absolutely right as what I can think of. So suggest me more what I should do. And there we are not talking about symptom evaluation. There we are talking about how to predict who is going to drop die in the next 10 years. And that becomes very, very critical. So I would like to close, but before that, I am going to discuss one quick case with Praneeth one-on-one. So Praneeth, and after that, we can have a closing discussion for this. So Praneeth, unmute yourself. I'm asking you a question.
Yeah, I'm ready.
Okay, so a 15-year-old kid who do not have any risk factors, who is otherwise fine, vegetarian kid, he goes to school and he's doing absolutely okay. He wants to participate in basketball and he wants to play in a league. And as a part of their school's protocol, anybody who needs to go on a league needs to get a screening ECG, because there is this whole debate about athletes having HOCM and whatnot. So this kid undergoes an ECG. And ECG shows T-wave inversions in the precordial leads, otherwise everything is fine. His initial assessment with a routine like what you would do for any person, which is your hemoglobin, A1C, TSH, lipids, all those, they're all normal. Just his ECG has got T-wave inversions, no ST changes, no nothing. He's a 15-year-old kid. So he's referred to a cardiologist, and cardiologist does an echo, which is normal, puts him on a treadmill. This kid, being athletic, goes 19 minutes on treadmill. It's an exercise limiting treadmill. It's not a ischemia treadmill. He goes 19 minutes on treadmill, and he doesn't get tired. The treadmill technician gets tired. So he says, finally, okay, kid, now you can stop it. And the treadmill is normal. There is no ST changes. Those T-wave inversions are present there, but there is no ST changes. So this kid comes back to you, 15-year-old kid, T-wave inversions, wants to participate in athletic activity, T-wave inversion, treadmill normal. What else can you suggest to risk stratify his future risk of cardiac event?
I don't know, Anoop. I think probably with treadmill being okay, with exercise, he is not having any issues. I would probably clear him, but I could not think of anything else at this point with his age and the history that you told me.
So we discussed calcium score as a risk factor. Well, at age 15, I don't think calcium score will add any value. And HSCRP, we can debate or whatnot. So anyway, the reason I'm asking this case is because statistics are statistics, but a case occurs in front of you, and now that dictates how you evaluate patients. So this index case that I'm telling you, he dropped died after 6 months of this treadmill while he was playing basketball. So immediately after his basketball session, while they were in a huddle where they were discussing about the game and whatnot, he was standing and he dropped asystole, or not asystole, sorry, no pulse, no event. EMS was called. He did undergo defibrillation or cardiac shock, and he was subsequently revived. After 10 days of all the intensive care and whatnot, he was eventually diagnosed with anomalous left main coming from right. He happens to be my cousin. He is alive right now, but he did have an oxic brain injury, and he underwent surgery for correction of anomalous left main. So the question here is, Praneeth,
Yeah.
was that T-wave inversion a clue? 15-year-old, we see T-wave inversions left and right.
I don't think so. I don't think that the inversions was the clue. And again, this is one index or one of that, what you call tails of that statistical curve, which should not dictate the way we behave in a routine practice, just like the celebrity deaths that we look into it. That is a chance thing. And I don't think we should take these exceptional cases into consideration when we practice in general.
Anybody in the audience thinks that we could have prevented this sudden cardiac death in this kid?
Anoop,
Sir,
the T-wave inversions are in which leads?
so T-wave inversions were in V2 to V4, I believe. I don't remember the numbers, but I think it was in the
L1 AVL were normal.
1 and AVL were normal, yes.
And V5, V6 were normal.
Sir, as far as I remember, but as I said,
Yeah,
I can't
that's
quote
one.
on that.
Secondly, one must realize while whether you make a diagnosis or not make a diagnosis, there are issues. But one must realize that exercise on a treadmill is different from exercise in real world and sports and other competitive sports, and also what they do in the gym, etc. So exercise on a treadmill is relatively lower in its say intensity, etc. It's not real world exercise. Be aware of it when you interpret exercise test and its tolerable.
So do you think that when you get these kind of individuals who have got some ECG changes, even if they fit in the pattern of what we would consider it as normal, but if there are any ECG changes, we should actively look for these kind of causes?
I'll put it this way. The type of T-wave inversions, and one must look at the electrocardiogram, the nature of the T-wave inversions. These are all very subtle signs. And we make, sometimes we do suspect, sometimes we fail, and we make mistakes also. Not everything can be diagnosed, and we also make mistakes. And that's that individual clinicians, how they look at that ECG in that patient at that age, that makes a difference. And these are all difficult diagnoses. Be aware of it.
Thank you, sir. It is 8:20. This is one of the longest we have stretched. Praneeth, your quick 30-second closing comments, and then we'll be done. Thank you.
Yeah, so it is not easy to kind of do these things, but we need to stick to our basics, do the right things on evaluating the patients. So history is something which should not be underestimated, and all the routine practice of getting these health packages and not looking at the physician and trying to interpret themselves, something should be discouraged, and people should stop doing that. A good detailed physical examination and history is something which is always valuable, and it should not be underestimated. And adding to the investigations to help you make a decision is the right way to go. And our practice patterns or our behavior should not be changed on the tails of the statistical curve, like these celebrity events or the example that you showed. And probably science grows and we'll be knowing many more. And we hopefully should prevent these sudden events, which is always painful to everyone. Thank you.
Thank you, Praneeth. Thank you all of you for attending this session a night before Diwali. Again, I wish you happy Diwali to all of you. And all these sessions are recorded. They should be there on YouTube at some point. And if you are not a part of WhatsApp group yet, I urge you to join, where we will be discussing these kind of sessions once they are over. Thank you all. We'll see you next Wednesday with a new topic. Good night. Thank you for sticking around so long. Take care.